Hello, welcome everyone. We're so glad you're here for today's John R. and Donna S. Hall lecture. Today's lecture is co-sponsored by the School of Engineering and by the Biophotonics Center. And before we actually get to the talk, I wanted to make sure I told you a little bit about John and Donna Hall. If I could have the next slide. So John Hall earned his Bachelor of Engineering in Chemical Engineering. He was magna cum laude graduate, and he played football. He was Vanderbilt's first academic All-American. He had a variety of work experience, but he ended up working for 40 years for Ashland Oil, moving up to become their CEO and chairman, and he retired at that level in 1997. He has served on the Vanderbilt University Board of Trust and served as its chairman. John and Donna are generous benefactors to the university and to a number of other educational and arts-related causes. And one of their very special contributions was to endow a chair in breast cancer research that was awarded a few years ago. So today's lecture is Wearable and Bedside Biophotonics Technologies at the Intersection between Personalized Medicine and Personal Health. And to introduce our speaker, I give you Professor Anita Mahadevan-Jansen.
You might actually want to hold the applause when we actually bring Dr. Bruce Tromberg on here. But Dr. Bruce Tromberg is the director of the Beckman Laser Institute and Medical Clinic, one of the leading biophotonics centers in the world, not just the United States, of course, not including the one at Vanderbilt. He pioneered the clinical translation of diffuse optical imaging for breast cancer. And that's something that he's very passionate about. Not that that's the only thing he's done. You know, he continues to innovate, and you'll hear plenty of that in today's talk. I met Bruce in 1992. I looked up. It was actually during my very first conference as a grad student, and he, according to CV, must have been a young faculty at that time. And we've continued to interact over the years. We're both passionate about clinical translation, and that's our common meeting ground, if you will. The other most important thing to remember is that Bruce here is an alum of Vanderbilt. He got his undergraduate degree here from Vanderbilt in chemistry and psychology. Again, something else I discovered in digging through his CV. He tells me he was here 44 years ago, and I did the math because I found out that he turned 60 this week. So please make sure and wish him happy birthday during the reception. But 44 years ago made him 16 when he came to Vanderbilt. Okay, so he graduated in 1979. He subsequently got his master's and PhD at UT Knoxville under Tuan Wudin before he went to the Beckman, UC Irvine and the Beckman Laser Institute, first as a postdoc, then as an associate director, acting director, finally director in 2003. And he's been there since. In terms of his accolades, I could go on. I'll just a couple of highlights. I know that he was one of the first editor-in-chief of the Journal of Biomedical Optics for the Biophotonics folks. You know, you're well aware of that journal, and he led that journal for 10 years. Is that about right? He's still on the editorial board of at least 3 different journals that I could find: Cancer Research, Molecular Imaging, and Measurement Science and Technology. He has given numerous plenaries and keynotes, and an interesting fact that I discovered is he's on 14 advisory councils or boards at this point in time, including the one for BME in our department here, BME department here. So I could go on, but I'll stop. I'll have Bruce come forward and tell us more about wearable and bedside biophotonics. Please join me in welcoming him.
Thank you, Anita. All right, I want to make sure all my AV stuff works. It's really wonderful to be here. As Anita said, I walked through the Vanderbilt gates 44 years ago. It's been a week of reminiscence since, you know, you hit that ancient 60. So some of you, you know, actually none of you are that old. So well, maybe 1 or 2 in the audience. So it's really quite a you know, kind of an unusual experience to do that and then come back to where you were an undergrad when you were 16 and see all the amazing growth. All of you and your hard work and brilliance have actually made my degree more valuable, so I'm very appreciative of that. Thank you very much. It's just a great pleasure to be here, especially with Duco and Anita, whom I've known since, I guess, a long, long time ago, 1992. And they were grad students at the time. And our field was just, really emerging, just beginning to develop. Photonics West, how many of you have gone to the Photonics West conference? So quite a lot of people. If we go back, like the first one I went to, I think was in 1987. And there were maybe 100 people in the biology and medicine area with lasers. Really small, and I think I basically got very lucky. All of you are lucky being in this field, but if you go back in time, I think we just got in the right place at the right time. And that's kind of a secret to growth in your career and success for grad students. We talked a little bit about this at lunch. It's grown to just a sort of tremendous size. There are 2,000 papers just in the bio area. But if you look at the specialization people in SPIE, they mark down that they're interested in biology and medicine, I think well over half the membership, maybe 2/3 of the membership. So there's enormous interest in this, and there's enormous potential for our technology. So part of what I'll do today is try to motivate excitement, perhaps, and stimulate some discussion about where some of these technologies can go. These are kind of early stages, both in terms of their applications, but also in terms of how you can advance the technology so that they can be worn and you can walk around with that information content and send it off to Apple and Google, who will own all of us at some point. But it's kind of exciting to think about. So I'm just also want to point out, because I know that there's a lot of interest here in the close collaborations with the medical school. There's wonderful collaboration and cooperativity. So I'm jointly appointed in biomedical engineering and surgery, and we have 5 of our faculty in biophotonics who are jointly appointed, and a 6th one who's in mechanical engineering. It's a challenge to do from a cultural point of view, but something that I really highly recommend. There are great, great payoffs. Engineering and medicine is finally, I think, being recognized for its importance and growth. Many of you may have noticed that the NIBIB director, Rod Pettigrew, has left, and he's gone to Texas A&M to head their Engineering in Medicine initiative, which is a major campus-wide initiative. University of Illinois, Urbana-Champaign, has their entire med school founded on the basis of engineering and medicine. All the curriculum has engineering embedded in it. So it's an exciting time to be working in engineering and medicine. A lot of it leads to medical devices and companies and technologies, and we've been very actively engaged in those, so I have to really disclose financial interests and collaborative interests with these companies, some of which I'm a co-founder of, and I'll be talking about some of these things. The Laser Institute, as Anita mentioned, it's a multidisciplinary center for optics and photonics. We have about 200 people. There are 21 faculty from 10 different departments across the university who are engaged, much like if you consider what you guys do here in terms of your matrix. But we have a building with a clinic, an operating room in our clinic. We do translational research with about 30 to 40 IRB protocols within our institute. We treat about 3,000 patients per year. And that's a kind of an interesting thing to have in a technology development center. So it's unusual to do therapy. We do a lot of diagnostics and imaging in our field. If you have the opportunity to do therapy, you see medicine a little bit differently. And it's a real, I guess, aspirational goal for us to provide information content that can be directly used to improve outcome for patients. We do a lot of commercialization as well. So we have a photonic incubator. I know that incubators and all these things are kind of popping up all over the place. We had an incubator, photonic incubator, going back to, it opened in 1999. And we've had a number of companies come from that. And just to sort of give you a feeling of the potential for optics and photonics, we've generated about half of the IP royalty revenue for our campus coming from biophotonics, well over $50 million. And that's on a therapeutic device. So that's really quite important. So these are actual scenes. You may recognize some of these faculty, Kristen Kelly, Bernard Choi. This is one of my graduate students, of devices that were easily able to move into the clinic. My research is kind of split between nonlinear optical microscopy and diffuse optical spectroscopy and imaging. I won't talk about the nonlinear microscopy, but I've been working on this since kind of the mid-90s, about 1996. And what we've evolved in over the years is really translating. Believe it or not, you can do nonlinear microscopy in people. We have wonderful nonlinear properties in our tissues. And we have a clinical study ongoing in many different areas where our biggest patient enrollment now is in looking at melanoma in situ and distinguishing between melanoma and dysplastic nevi. Really difficult clinical decision making. It can be done at the bedside. There are important needs in terms of advancing the optics and photonics, but this is a real fly-through from a patient, living, breathing. We're going into the dermis here. These are actually capillary loops. We'll come back up to the top, and you can see the epithelial cells, and this is all the blue stuff is coming from collagen. So a very powerful approach. That's all I'll talk about with this. I'm going to really focus on these technologies in diffuse optics, where we're not concerned about the wave properties of light. We just treat photons as particles. And all of these techniques, as you'll see as I begin my talk more, are model-based approaches. I won't go into details of the models, but using models in conjunction with clever hardware approaches for controlling optical path length, and I'll go into more detail on that, allows us to get very unique information out about biological tissues. So I also wanted to kind of contextualize this in the sense of, what are we all doing this for, and what is a bigger picture problem that concerns all of us? And that's related to healthcare expenditures. So about 20% of our GDP, close to $3 trillion. Actually, in 2015, it went over $3 trillion. You can tell from kind of the shape of this curve that it continues to go up. So, this is going to bankrupt the country eventually, and people recognize this. So there's been, this rate of increase is 50-fold the increase of wages and 5-fold the increase of our GDP. It's clearly not sustainable from an economic point of view. And this is my simple-minded analysis of this. If you kind of look at this big picture, you say, well, where are all these expenses coming from? So I've sort of reduced this into really 3 basic components. The cost drivers for all of this are in the fee-for-service structure that we have. Every time you go to a doctor's office, you're charged. Every time you get an ultrasound, you're charged, or an imaging. So increasingly in managed care, if you're a patient that's being managed for, let's say, heart failure or diabetes or whatever the indication may be, there will be an allocation of expenditure that the managed care organization will agree to. And then the healthcare provider has to figure out how to give you effective care that improves your outcome within the confines of that absolute dollar amount that's been allocated. So this is a factor that's really changing slowly, but it will change, and it needs to be altered, and it needs to have more homogeneity around the country. And even in locations like in the same city, you can get different fees for echocardiography. This can vary wildly across town from one portion of a city to another. The second major cost driver are hospital stays. We know that tertiary care is expensive. And if you go into the hospital, it's going to cost a lot of money. And then when you leave the hospital, you really shouldn't go back in. And insurance companies won't even reimburse you if you go back in within 30 days. There's kind of this 30-day window. So people want to drive this down. And then, of course, chronic disease and end-of-life processes. So this is a very interesting statistic. 5% of the population accounts for 50% of our healthcare spending. And then if you zero in on that just a little bit more, you see, what are the big problems from a disease point of view that are driving this? And there's circulatory diseases. That's $500 billion in and of itself. Obesity and diabetes and cancer, sort of the usual suspects. So my talk will be a little bit about how we can potentially introduce some innovation to attack and address those problems. But just to really underscore, what do we need overall from a technology point of view? We need to figure out how to develop technologies that will prevent disease in the first place. It may not be a technology. It may be something that is helping your lifestyle change. But that will be the focus of what I'm trying to talk about. We need better monitoring after people leave hospitals. We just can't let them go back in. And there are amazing opportunities, both from a scientific point of view and a commercialization point of view, to develop better devices to figure out if patients are compliant. Are they taking their medication? Are they doing their physical therapy? Are they having another event that we could detect, possibly remotely? passive monitoring devices, so it's not all about having cameras everywhere, and not everybody wants cameras everywhere. So there are opportunities for better monitoring. And then, you know, ultimately, this is where the equation is critical. We have to improve patient outcome and satisfaction. And it's really quite gratifying. I think if you talk to hospital CEOs, if you talk to med school deans, they're really thinking quite differently. I recently chaired the search committee for our dean of the School of Medicine, and I was really very surprised to hear deans come in and say, we have to improve patient satisfaction. I really never thought that they were thinking about that. So I think there's been a cultural change in medicine that has driven opportunities for us to partner even better with schools of medicine and hospitals to do these sort of three fundamental things. So now that I've kind of laid out what's the big picture challenge, let me give you the state of the art in one place in a couple of slides on what medical optics and medical photonics is. Because as I mentioned, back in 1992 or 1987 or 1982, when the Beckman Laser Institute was initiated, we were formed in '82 when I think there was virtually nothing going on in medical optics. There were some lasers that were cutting things. People were hopeful to get picosecond pulses. As we know now, you know, femtoseconds are everywhere, but that wasn't even on the radar screen. So if you look at medical optics, it's sort of broadly broken down into therapeutics and medical lasers. You have lasers for cutaneous laser treatments and cutaneous laser therapies and ophthalmic therapies. This is the most popular outpatient laser surgical procedure in the United States. There are close to 600,000 ophthalmic procedures that are done for refractive surgery in the United States, elective procedures. And they're done, many of them, with femtosecond lasers. How many of you have heard of all-laser LASIK? You should hear of all-laser LASIK. It's the coolest thing. It uses a femtosecond to make a flap on the cornea rather than a surgical blade to make a flap, which the imagery of that is horrible. Think of a blade slicing your cornea. Not very good. Kenny, you don't mind. But you can do that with light, and you can lift up a flap, and then you can reshape the corneal stroma. Hundreds of thousands of patients per year are actually being treated with these approaches. In terms of diagnostics, we have a number of very well-established now diagnostic devices that are based on technologies that our field has been working on and pioneering. And I sort of broadly break these down into oximetry devices, both tissue and pulse oximetry. A lot of this is going in brain oximetry, for example, in neonatal intensive care, pediatric intensive care, but also pulse oximetry, increasingly in anesthesia monitoring, looking at oxygenation in the brain. This is about $1 billion a year market. OCT is about $1 billion a year market, and you guys are all very familiar with this, both in ophthalmology and in cardiovascular applications. Perfusion imaging, how many of you are familiar with the Novadak indocyanine green technology? So this is really taking off all over. Surgeons are embracing this like it's a brand new thing. Of course, we in our field have been working on it for, indocyanine green was introduced, I think, in 1955 or something like that. Now there are a bunch of companies that are popping up developing imaging devices specifically to co-register white light and fluorescence imaging to help with surgical guidance, both in open field surgery, but increasingly with endoscopic and intuitive surgical. How many, I think you all know intuitive surgical, right? They make the Da Vinci robot. So one of the biggest, most successful medical device companies ever, and it's just growing like crazy. Integrated into their guidance system is the technology that Novadak developed. And Novadak is actually just recently acquired by Stryker. So this is a really fast-moving area. And endoscopy. Endoscopy is really the heavyweight. So probably more than half of this market is accounted for by endoscopy approaches. So these are the broad areas. We're working on all of these, both the therapy and the diagnostic side, but not the standard instruments that you can buy off the shelf. You know, where are the next big opportunities? And so this is a partially, you know, my biased view of where the big opportunities are and will help direct really the focus and the content of my talk. We look in the near infrared and the short wavelength infrared. All those technologies are by and large, you know, single wavelength types of approaches. But as we know from spectroscopy, information content comes from broadband types of measurements. If we look across the visible to near infrared to SWIR regions, we see lots of beautiful structure, lots of characteristic chemical structure. And if we look at absorption peaks of components like collagen, water, lipid, deoxyhemoglobin, oxyhemoglobin, they're all very visible and accessible. And when you kind of add these components up, that's more than 85% of all of tissue composition. So if you can characterize these components, both from a static compositional point of view, as well as their dynamics, there's a lot that you can potentially do and discover in medicine, and that's really what I'll be talking about. But some of the big challenges, most of you know about the near-infrared window and multiple light scattering. This is where absorption is falling off quite substantially, and you have light scattering as the dominant light propagation mechanism. So this is my personal view of light scattering, taken from two different angles. This is me with 850 nanometer LEDs in my mouth. So I have two of them in my mouth, and there's no external illumination at all. You can see from my pupils, which are fully dilated, that light is propagating several centimeters, both through hard tissue and soft tissue. If I didn't tell you that the light was in my mouth, you don't know. It's completely lost all of its direction through random propagation, multiple light scattering. The scattering lengths in tissue in the near-infrared are like 40 microns, 20 to 40 microns. The absorption lengths in the near-infrared are 10 centimeters, so vastly different spatial scales. This is a picture of me, same 850 nanometer light, with an image of me taken from the outside. So you can see I have this really nice, healthy, diffuse glow. You can't see any of the cutaneous imperfections that you would see with visible light or even, blue light, which looks horrible. And I actually didn't put that slide in because I look so bad under blue light. It's just insane. But the reason why I have this nice glow is because the 850 nanometer light goes in beneath the surface. We're not looking at specular. This is actually, I have orthogonal polarizers here. So we're looking at light propagating beneath the surface, bouncing around, coming back to the imaging camera. And by the way, the imaging camera in this particular image is a $250 IR blocking filter removed Canon Rebel. So it's not like a $40,000 cool CCD or CMOS. It's a really consumer-grade device. And similar type of thing here, really inexpensive sensors. This information it's bearing, the light coming back is bearing information about oxyhemoglobin, deoxyhemoglobin, collagen content, all those things that I showed you. But the challenge is, how do we squeeze all that out? How do we get quantitative about it? How do we figure out where the light came from in the first place? Can we solve an inverse scattering problem? And I'll have to come back to talk details about that, or you'll have to come, some of you have come to our computational biophotonics course, where we literally lay out all the different approaches for doing exactly those things. I'm just going to summarize all of that in one slide right now. And so the answer is, what we do is we use light, but we have to control the path length. So we're trying to turn the body into a cuvette. A cuvette is a device of known path length, 1 centimeter typically. We shine light into it. Generally, there's no turbidity to it. So we can use Beer's law to calculate the concentration of molecules that are in that cuvette. We don't know what that path length is in the body, but we have molecules, and we know what their extinction coefficients are. How do we determine the path length? We control light in space, time, and wavelength. So if we really control the light, its spatial, spectral, and temporal features, then we can calculate path length, and then we can determine the composition. We can turn that into measurements of perfusion and metabolism. And that's what my talk will be about. Applications and examples of technologies that are doing that. So just to help you kind of think through this, in terms of controlling light in time, if we think of light in the real domain, if we take a short pulse of light, like a picosecond pulse of light, when we put it into a turbid material, then the photons in the pulse, all still propagating, they don't violate the laws of physics, they're all moving at the velocity of light, but they will take multiple paths, and therefore that pulse will spread out in time. So if I have a detector some distance away from my source, I can measure that temporal point spread function, and I can turn that back, solving an inverse problem, into the actual path length of the photons. I can do that in space. So rather than taking a point of light in time, I can take a point of light in space, and everybody has done this. You can visualize how, I take that laser pointer, I hit a spot on my skin, it will spread out. If I have a detector with enough dynamic range, I could image that sufficiently far away from the source so that I could calculate what the absorption and scattering properties are and the path length inside of my tissue. I could also have fiber optics placed some distance away, so I'm picking up all the reflected light, so that's controlling it in space. And then in wavelength, as you change the wavelength, you change the penetration depth. Everybody kind of knows this intuitively. That near-infrared light I showed you goes very deep. Blue light or green light is absorbed strongly by hemoglobin, and it won't go very deep. It's very, very superficial. I can do all these things that I do in the real domain and the frequency domain, and there are some advantages to doing it in the frequency domain, both computationally and hardware-wise. So we work a lot in the frequency domain in my lab. Instead of taking a pulse of light, we'll intensity modulate a light sinusoidally in time, and then we can measure these intensity modulated waves, which have very, very long wavelengths before they go into tissue, several meters. When they go into tissue, they're carrying photons which are scattered multiply, and it slows the phase velocity of the wave down by 1/10 or 1/100th of the velocity of light. So if we measure that phase velocity, which we can do by measuring the phase and the amplitude of the wave, then we can calculate path length and what's inside tissue. So you can make all these similar arguments for real domain to frequency domain. Intensity modulation in time, I can look at a lot of frequencies, and that's very similar to a pulse. A pulse contains all frequencies. I can do this in space as well. I can intensity modulate light in space, and I can look at the frequency-dependent response of the tissue, and the same thing in wavelength. And the beauty of this stuff is that I can now be very quantitative. I can measure absorption, I can measure scattering, I can look at this in localization in space, and then I can make measurements on different time scales that are quantitative. So I can look at oscillations that are on sub-second time scales. I can look at dynamics over minutes. I can come back and measure the same person days, weeks, months later. And I'll show examples of all of those emerging time scales. So now I just want to show you some examples of technologies that we're using and applications of those, and hopefully that will tie all of that more abstract, how do we do all of this together. So one technology we've worked on is broadband temporal frequency domain. We also combine this with time-independent spectroscopy, or CW NIRS. What we are doing is, as I mentioned before, intensity modulating laser diodes. We launch that light combined with white light into tissue. So this is a somewhat small portable instrument, and I'll refer a little bit later to how we're making this wearable. But this has a handheld probe. We can take that probe and just scan that across tissue. And if there is a subsurface heterogeneity or structure, in every location where the probe is, we get a full absorption spectrum, a whole fingerprint of what's inside of the tissue, looking centimeters beneath the surface. How deep we're looking depends on how far we separate the source and the detector. Our separations are typically about 3 centimeters, so our mean interrogation depth is about 1 centimeter to 1.5 centimeters beneath the surface. So if there's a tumor, then we'll see a perturbation in the spectra. Any region that I put the probe, I can form an image from any of these contrast features, from water, from lipid, oxyhemoglobin, deoxyhemoglobin. I can look at scattering profiles, get the full wavelength dependence of scattering, and I can form an image from any one of those contrast elements. So one application of this is in breast cancer, and we've been working on this for many years, looking at sort of 2 major questions. Differential diagnosis. Is a tumor malignant or benign? And there are a large number of unnecessary biopsies that are done in mammographically dense breast tissue, particularly with younger women, women who are perimenopausal, that x-rays, mammography just doesn't work. So these are BI-RADS 3, BI-RADS 4, if you're familiar with that terminology, patients. And, it's a coin toss as when someone feels a palpable lesion as to whether it's a malignant or benign tumor. And then the second major question that we're looking at is a tumor that's undergoing, or a patient undergoing, pre-surgical neoadjuvant chemotherapy, is that patient responding to therapy? They may undergo therapy for 3 to 6 months, but you don't actually know. The clinical standard of care is palpation. They try to feel if the tumor is shrinking. So we want to know, is the tumor responding very soon, after the first infusion, within a week, as fast as possible, so that that patient doesn't have to endure unnecessary chemotherapy? Or if the chemotherapy doesn't work, and this is the engineering ideal, could we take that and apply that to a feedback loop, tell the oncologist it's not working, and let them try another cocktail with a different mechanism, and then optimize that for that individual patient, rather than have that patient just sort of be subject to statistical considerations for the chemotherapeutic approach. So here are some images that, from an actual patient. We can form images of any of those contrast elements. This is a patient, a postmenopausal subject with about a 2.5 centimeter mass. And you can see very nice contrast in oxyhemoglobin. Here's normal breast, deoxy, water, and lipid. As the tumors grow, they actually displace lipid. And we've done a lot with the spectroscopic information. I won't go into a lot of details on that, but I just want to show you the types of images you can form. And then we can combine multiple parameters into a high contrast index. And here we're typically seeing maybe 5, 6, 7-fold contrast with those indices in 1 centimeter and above types of tumors. There's no compression. The patients are just in a reclining geometry, and it's scanning just much like ultrasound, but it's quantitative information. So if you've ever seen an ultrasound, it can be very subjective, and the operator and the angle and different operators, and it's really hard to get actual functional metabolic information content. So we've recently completed a multi-center trial that was supported by NIH and the American College of Radiology Imaging Networks. This trial, where we built multiple instruments and sent them to universities all around the country, involved looking at responses of patients to pre-surgical neoadjuvant chemotherapy. And here is a case of a responder. We're looking at that tissue optical index at baseline. You can see there's an early therapy response already for this subject. Mid-therapy, in this particular patient, this mid-therapy was about 4 months. So we're following these patients out over months, and here's post-therapy prior to surgery. We use, when the patients go to surgery and then it's removed, the pathologist will make a determination at that point. Is this a complete response or a non-complete response? So this is a binary classification. And this is an FDA-cleared endpoint for the determination of the success of neoadjuvant chemotherapy. So what we've done, it's a surrogate for 5-year survival. What we've done is we've set up our trial to say, can our optical endpoint predict an FDA-cleared endpoint for that patient? Can we, using an optical measurement, predict pathologic complete response or non-complete response? So that was the goal of the trial. And so here's a non-responder. So you see there are changes for sure, but they're not as substantial. And what we're seeing is you need to have about a 40% change in this tissue optical index in order to be confident that the patient will be a responder. Here are a couple of case studies illustrating the power of the early information content. So here's a patient at baseline. So this is a 2-centimeter tumor. It's a triple-negative breast cancer, which is particularly difficult from a treatment point of view because there are no therapeutic targets. There are no molecular targets to treat patients with. And here's an ultrasound image. This is a classic kind of hypoechoic ultrasound image where you see a mass, but no additional information content to the mass. Here's dynamic contrast enhanced MRI. You can see the enhancement at baseline. So you see 3 different modalities providing really kind of interesting complementary information content. Here's that same patient with the ultrasound. You can't really do MRI on a weekly basis. You're lucky if you get the baseline and possibly sometimes a midpoint or just prior to surgery. But it's definitely not clinical standard of care in all centers. But here's an ultrasound 1 week in. There's no size change in terms of the ultrasound, but there's already a 30% change in the tissue optical index just 1 week after the first infusion. And that patient will come back for multiple infusions. We've extended this to whole breast imaging, and there's a lot of interest in looking at risk and also looking at chemopreventative approaches. So have you heard of tamoxifen? So tamoxifen is given in the case of breast cancer, particularly in hormone-positive breast cancer, in order to reduce your risk of developing breast cancer again. So we've been able to look at entire breast images and be able to look at, for example, baseline and changes in density. So it's not just a change in brightness that you see with mammography, it's a change in composition. This is a patient, 1 year. We followed this patient for a year. And we've got patients now we followed for 2 years with tamoxifen. Patients take tamoxifen for 5 years, and in some cases for 10 years. It doesn't always work, and what I found also is that there are polymorphisms in a cytochrome P450 pathway, CYP2D6, which, if you have them, you may not be metabolizing tamoxifen. Interestingly, tamoxifen is not the drug, it's a prodrug. So it's converted by this cytochrome P450 pathway into endoxifen. Endoxifen is the active agent. And remarkably, it's not clinical standard of care to look to see if you have these polymorphisms or even to measure your endoxifen levels. So interestingly, those are some potential targets that might be able to improve outcomes, but imaging can be very nicely correlated and we can complement that type of work. We've extended the technology to looking at obesity. And much of the work that you hear about obesity is in visceral fat. Subcutaneous fat is kind of poorly understood. But clearly, with accumulation of subcutaneous fat, there's a buildup of insulin resistance. Insulin resistance is a bad prognostic factor for the development of diabetes and cardiovascular disease. So we did a study recently where we looked at patients who were put on calorie-restricted diets using the same probe and same mapping techniques. Here's an ultrasound cross-sectional view of what your belly may look like. You can see a nice subcutaneous adipose layer, but there's no other information content with that. But if we look optically, we see at baseline a very beautiful lipid peak here, a nice water peak here. We can see changes in the deoxyhemoglobin structure just 6 weeks into a calorie-restricted diet for a patient. We also are able to see baseline to 6 weeks in really quite dramatic scattering changes, which are consistent with the shrinkage of adipocytes and the activation of mitochondrial metabolism in adipocytes. So we can do exactly what we did with our breast imaging. We can form images of this is, for example, tissue scattering amplitude of a person's abdomen. Of course, it's the subcutaneous information content that's wrapped around their abdomen. This is the tissue water content. And 12 weeks on a calorie-restricted diet, substantial changes. The amplitude changes are reflective, as I mentioned before, of a shrinkage of adipocytes, which we get from the wavelength dependence of scattering, the A and the B parameters in the scattering fit. And the water content is suggestive of increased perfusion. So we're seeing more blood, more water volume. There's greater extraction of oxygen, so we see increases in deoxyhemoglobin. So what's interesting, and this is what people have been trying to measure and accomplish, is we're kind of waking up the adipocyte metabolism. They're extracting, the mitochondria are extracting more oxygen, there's increased blood flow, and this is exactly the clinical result that you want to see. We've been able to correlate these changes and then predict whether patients will actually lose weight. Another kind of complement to reducing adipocyte and lipid burden is building muscle. And so this is very, very difficult to do, particularly in calf muscle. Of course, it's important because we all want to dunk a basketball. I mean, I'm still working on it. But that's the real motivation is, as we age, we lose strength in our legs. And I think as we sit behind the desks, we also do as well. And that causes probably the greatest existential risk for seniors. Does anybody know what that is? Falling. So, you would like to, we've explored a number of really interesting ways to try to build muscle and using optics as a feedback approach. And we want to do this with reduced load to the joints. So I'll just show you, just a quick result of calf muscle training. And we explored different calf muscle training techniques. But again, we're mapping calf muscle here. We can measure baseline. You can see actually the muscle head groups coming in. We're measuring here total combination hemoglobin and myoglobin concentration. This is 5 weeks of strength training. And you can see really quite impressive remodeling changes. How do we validate that? Well, we've done dual energy X-ray of all of our subjects, and we're able to look at lean mass fraction, and we've been able to correlate that very nicely with water content in the muscle, in the calf. We also can look at lipid fraction from DEXA, and we've been able to correlate that with all of our optical measurements. So we feel like we have a really interesting benchtop, low-cost way, potentially, of looking at not just, there's a lot of work done in near-infrared spectroscopy in muscle activation. Like if you work your muscle, you're going to see immediate extraction of hemoglobin. But what about long-term? You need to have quantitative techniques that can measure people over time in order to say whether there's a gain or a change in the long term. So kind of in the short term, we've done a lot of work where we put people on exercise carts, and these are wearable probes. And it's actually collaboration with us in Hamamatsu Photonics. So this is a time domain system. Three wavelengths, ultra-short pulses. They're going into vastus lateralis, the thigh muscle over here, and into the brain, so into prefrontal cortex. And there's some really interesting things you can begin to address. I'm sure, so like all of you exercise and all of you have stopped exercising. And if you ever wondered, could I push myself a little harder? Is it my brain? Is it my body? What's the communication between the two? So we've done some work in this, and I won't have time to go into detail, but here's a kind of an interesting signature that we found. So this is a subject who's resting, then you can see unloaded pedaling. We're looking at brain and muscle tissue oxygen saturation, and there's 20 watts per minute that's applied in a ramp until the subject is exhausted. So no one says stop. You just stop eventually. You can't really pedal anymore. So here's brain oxygenation. It looks pretty good, and the brain is highly conserved, and it's going to make all of the blood flow to the brain in order to survive and be able to think and operate. The muscle, of course, in order for it to work, you see immediately a drop in saturation. There's a huge extraction in order to get muscle contraction to work and to maintain and support the generation of force. It starts to sort of level off, and what we see, this is a gradual transition between aerobic and anaerobic metabolism. We can look in more detail at some of the other tracings, and we can actually pinpoint the differences in metabolic processes that your muscle is undergoing. But what's interesting is that we start to see a drop in brain oxygenation. Now when that person, and so this is kind of a hallmark, it's a harbinger of that person is going to stop exercising. And so we've been able to kind of look at that and predict to some extent when people are going to quit. We've also been able to train people to extend this saturation drop a little further and a little further to improve their performance. So interesting potential for that type of stuff. Let me switch gears a little bit. Now that was all temporal frequency domain, and they were kind of contact probes. Now I'll get into spatial frequency domain, and the concept, the ideas behind that are really exactly the same. They are that light absorption and scattering are taking place on different spatial scales in tissues. So if we, in tissue, project patterns of light and then image them with a camera, and we look at the blurring of these patterns, we change the frequencies, we change the phases at each frequency, we can demodulate these images using standard demodulation approaches, then we can quantitatively measure absorption, scattering, and fluorescence in our field of view, and we can localize structures in 3D. So the reason why this works is because tissue, as many of you know, is actually a low-pass filter. So if I have low-frequency structured light hitting my tissue, this is a cross-sectional view with, these are model, this is not an actual cross-sectional view of tissue. These are maps of photon density. I get deeper mean penetrance with low-frequency structured light compared to high-frequency structured light. So I'm interrogating different spatial sensitivity maps. And if I look at the reflectance as a function of frequency and fit that to a model, then I can calculate absorption and scattering. So my two sort of big implications, I can map optical properties in every pixel in my field of view, and I can do depth-resolved imaging. So I can use multiple frequencies and figure out like what's at the surface and what's beneath the surface. Here's just kind of a visual example of that. I have 4 tubes in this experiment that are buried up to 4 millimeters beneath the surface. They have a fluorophore in them. They're half a millimeter in diameter, these tubes, and this is tissue phantom. And here are the patterns that are being projected at different frequencies. Here's the demodulated fluorescence, and these are the line profiles that you can see. So as we go to higher and higher frequencies, the deeper tubes disappear. there is no sensitivity to those deeper tubes. We're only seeing the superficial structures. And you can imagine if you look at enough frequencies, then you can potentially reconstruct tomographically the depth and even the composition of these tubes. And you can do this over several millimeters in depth. Up to, it depends on the material, but we've gone 5, 6, 7, 8 millimeters in depth. Depends on the turbidity of the material and the layered structures. I don't know if this came out that well. Maybe we could dim the lights a little. Well, this is not too bad. So this is another personal illustration of that spatial frequency dependence. So here I am, 850 nanometer light. This is just a simple DC reflectance image at 0 frequency. Here is at 0.2 per millimeter. And Eric, you probably can pick out all kinds of problems here. So this is looking at more superficial structures. Just visually, you see I look different. And it's interrogating more superficial cutaneous structures. Here, the information content is coming from deeper structures. And you can imagine I can go to higher and higher frequencies and get more superficial stuff. It's kind of like changing optical wavelength without having to change the color of the light. So one of the first applications of this was in dynamic brain function imaging. We did a lot of work to look at things like cortical spreading depression and functional brain attributes. So here's an experiment so David Kucha, when he was a grad student in my group, and now he's the CEO and the CTO of the company that's commercializing it, Modulated Imaging, working with neuroscientist Ron Frostig. So here we're looking at a scattering wave that propagates across the cortex with the depolarization and then repolarization that occurs when you inject potassium chloride into the brain and launch a spreading depression wave that propagates at a few millimeters per minute. So this is accelerated in speed. But what you see is that this scattering wave that propagates across the surface, behind it, you're going to see as the neurons sort of come back awake and start extracting oxygen, you'll see in space and time an increase in deoxyhemoglobin, an increase in extraction as this wave propagates across the surface. So the depolarization, the neuronal effect, is measurable by the scattering phenomenon, and then the compositional change is telling us about the extraction and the metabolism. So we can combine coherent light sources with structured light, and the coherence encodes information on speckle, and we can use structured light propagation in combination with this to get flow, which is the speckle blurring, with the structured light, which tells us about the composition. It tells us about the scattering and the absorption, and if we do that at multiple wavelengths, then we can pull out all that information simultaneously. So here's kind of another interesting brain model experiment. We're looking at a cardiac arrest model in a rat. You know, what we'd like to know is after cardiac arrest and resuscitation, has it been successful? Half the people who have heart attacks don't recover at all. Of those who do recover, roughly half have brain damage, some sort of neuronal impairment. So this is a really important area of research, very difficult to control. We have an ICU with a cardiac arrest model with a rat, working with a neurologist in our group. And so what you see initially, we're mapping blood flow and oxygen saturation in these two panels, monitoring blood pressure at baseline, brain blood flow, brain oxygen saturation, and the EEG signals. So this is baseline. You'll see these change dramatically at cardiac arrest. So with arrest, there's no pressure, no flow to the brain, very low oxygen saturation, and then the EEGs flatline. Okay, now Yama Akbari, he's the neurosurgeon, neurointensivist, actually does resuscitation to the rat. He does cardiac massage. And you see dramatically a restoration of blood pressure, of blood flow, high oxygen saturation, but amazingly, you see still no brain electrical activity. And then as you continue to move across, what you see ultimately in the recovery phase, you're going to see a decrease in blood flow, which is coincident with an increase in extraction. When flow is reduced, there's greater extraction. The brain consumes oxygen, saturation drops, and then you see stabilization of blood pressure. So you see that decrease in flow, and all of this stuff now appears to be coincident with EEG. But the really interesting thing about this, and where we're really trying to sort of study, there are optical signatures that are potentially harbingers or characteristic of these changes and potentially could predict the efficacy of resuscitation, and they occur before any brain electrical activity. So in combination, the two, we think, have a lot of promise. Your hand is a lot easier to access than the brain of a rat model in cardiac arrest. So we do a lot of work with that. This is one of my students, and we like to torture ourselves with blood pressure cuffs and things like that. So here we are. He's got a blood pressure cuff on his arm. This is oxy and deoxyhemoglobin. Here's the speckle flow. Initially, he has a cuff on his arm. This is the cuff release. And you can see a dramatic resurgence after the release of the cuff of oxygenated hemoglobin back into his hand, a drop in deoxyhemoglobin. Here's the flow increasing. It's actually oscillating, and there's some really interesting information on respiration that you can get from that. But the combination of the flow and the oxy and the deoxy, and what we've done here is rather than shifting phases, all of these things are done at very, very high information content, 15 frames per second, so that we can get lots of things dynamically, and the combination of the two are the metabolic rate of oxygen consumption. So I won't go into a lot of details on how we do that, but we can calculate quantitatively what the actual metabolic rate of oxygen consumption is by looking both at the combination of speckle, oxyhemoglobin concentration change, and deoxyhemoglobin change. And then we can see very nice time oscillations in the signal that are reflective of oscillations in arterial function. So these are what are called Meyer waves, and they're telling us about the health and the viability of part of your nervous system, sympathetic nervous system. There are also oscillations of the heartbeat riding on top of that. And then if we go to really even higher frame rates, 100 frames per second, this is just the raw signal that we see. And this is work that Michael Geisen, an MD PhD student in my lab, did. So you see on cuff release, just looking at the raw signal, there's not really much information content. But if we demodulate all these signals, separate them into all their components, which are the absorption, the scattering, and the speckle, they're all fluctuating in time. And we can pull them out in different regions. So we see oscillations in the scattering signal, oscillations in what we call the speckle plethysmogram. So this is a flow oscillation, not the pressure wave oscillation. And then we see absorption oscillations, and that is reflective of the traditional PPG waveform. And here is, so we amplify this a little bit, and let me actually kind of move to really interesting dynamics. We're looking in two different locations. So this is his arm, and you can see his heart beating. This is his thumb, so we're looking just like at this part of his hand. And you can look in different locations to see these oscillations. So the bright, dark, that's the blood flowing in and out. And you can almost imagine, and we're just really at the beginning of this, that coming from these different regions, there's a little bit of a shifting in time. This sharp peak is the left ventricle squeezing blood out. That's the left ventricular ejection. This is the notch, the dicrotic notch, which is the aortic valve snapping out and snapping back shut. So that causes this oscillation in the flow index, which is an extremely sensitive measurement. And then there are multiple elasticity reflections that are occurring as the blood encounters branching structures in the arterial system. And that's reflective of your vascular elasticity. A lot of underlying information content in that time-varying signature. And we've been able to sort of reduce this now to a wearable sensor. So this is a clip-on device. It's being commercialized by some of our former grad students, two of Bernard's students, one of my, Bernard Choi's, and one of my former students. So they have this little clip-on that's measuring these speckle fluctuations, which are reflective of microvascular perfusion. You can put it on your toe, on your fingertip. It's not pulse oximetry. It's actually measuring blood flow. And there's a huge amount of information content. And where we're trying to mine that is looking at the difference between the flow, particles that are flowing, and the pressure wave. And the time delay between the pressure wave and the flowing particles can potentially be indicative of new features like vascular stiffness that are not otherwise measurable using any other techniques. I just want to, from a view of the future and a view of the past, I talked about the time domain or the frequency domain techniques. When I first started working on them, this is about 1990. This is only a part of the giant optical table that took up the whole room. And then we got onto carts. Now we have tabletop devices. This is actually a mock-up of our ASIC-based wearable sensor. And this is a real ASIC, which we just got back from the foundry. We've boarded it up now. And this does gigahertz bandwidth frequency domain tissue spectroscopy measurements. So you can see the remarkable trajectory. And certainly, for the students here, I like to kind of think back over 30 years and the technologies and how they've progressed. And I know that you can't predict the future. We've shown that very clearly. But we know that there are going to be fantastic things that you guys will be talking about over the course of your careers. So let me try to summarize this. We've got biophotonics and personal health care. And we've got, very beautiful advanced technologies coming from our field. And they potentially can be integrated into very simple form factors that will expand the access of very sophisticated measurements that back in the 90s, who ever even thought you could take a giant spectroscopy lab and put it on a chip? But now it's routinely done. Any of you have Apple Watches or Fitbits or the equivalent? So those are ASICs. And when we first started working with PPG signals, it was really difficult to actually get those measurements. So this is going to have a huge impact. There are applications in exercise, diet, medication. Feedback will help close the loop in clinical care. Ideally, and this is the crazy hope, that it may help people prevent disease and stay out of hospitals in the first place. That will certainly lead to reduced costs. We're already seeing this really other interesting feature, getting data 24/7 from very large populations who are wearing devices, who are subscribers to 23andMe and Ancestry.com and have their genotype. These are huge, huge studies. We struggle to get 50 patients in a clinical protocol. But with these consumer devices, you can query patients, or actually volunteers, about their habits. You can get data streaming from their wearable devices. So that's going to provide enormous new power to accelerate and discover new endpoints. But from a medical point of view, putting on sort of the skeptic's hat, what we have to do is link these measurements to clinical outcome and ultimately prove that they are cost effective. So finally, I just want to acknowledge that I tried to give a very broad overview of many different things with lots of collaborators and funding support over the years. And so, acknowledging all of the work that we've done, and thank you very much for your attention.
Although we're actually past the hour of 5 o'clock, and I can see it's including, I would like to give an opportunity for a couple of questions for anyone.